Okay, so we're back today to talk about viruses. We could also call viruses like a body snatcher. And the reason I say that is because what the virus does outside the body is absolutely nothing. But once it gets inside of a cell, it like takes over the cellular factory of that individual cell. And it's like, we're going to make more copies of me. None of what you want to do. Let's do me. And so it makes more and more copies of itself and it keeps infecting more and more cells and it kind of becomes like this huge gigantic virus that inhibits your body. So viruses are actually pretty cool. They are very much body snatchers. They take over the cellular environment and use the cellular mechanism to make more replications of itself. They also have the ability to mutate spontaneously, so getting them trapped and under control can sometimes be a huge undertaking. Let's march forward with some learning outcomes. Here they are. Here's some more. And let's start here. So today we're going to be kind of covering a couple of different medication types to treat things like influenza, herpes, RSV, and HIV. Actually, we can mark RSV off there. We're not going to cover that one. But with these medications, I just want to let you know that sometimes our drug therapy is a little bit limited in what we can do as far as treating a virus. Instead, when we're talking about viruses, we want to really focus our aims on preventing them from ever entering the body if possible. So we'll go through a couple of different cases and a couple of different disease processes, and here we go. So with the antivirals, this is the primary goal that they're going to try to do. They're going to try to prevent the virus from replicating. They're going to prevent it from actually going and attacking the cell. Maybe they're going to try to mess up its genetic code so that it can't replicate very well. And then ultimately, we want to inhibit it making copies of itself. So kind of understanding how the virus replicates and does what it does in order to make more of itself really kind of helps us to get good pharmacological therapy in order to help control the virus replication within the human body. Probably one of the biggest disease processes or viruses that have been studied most intently over the last decade or so is HIV. We know a lot about HIV. We understand how it gets into the cell and we know the different parts and the different pieces. So putting that into your brain may be helpful for you as you go through learning about the pharmacology. There are lots of different types of HIVs. There's HIV type 1, HIV type 2, and then there's like, I don't know, 25 subtypes of HIV. All the different subtypes of HIV really help us to target our pharmacological therapy as to how we need to be treating this patient. Ultimately, the goals of HIV therapy are the same as for any antiviral. Here is the different drug combinations that you may see a patient on. I don't want you to memorize these, please don't. But this is the prescription put out by the Institutes of Health and by the CDC, the Centers for Disease Control, that talks about the best way that they're finding right now in a population of people who've got HIV. This is the best regimens that they can give us in order to help to keep their disease under control. Again, don't memorize this. I just want to let you know that sometimes the formulas that we get change from year to year, and then whatever they're prescribed to our patients, we have to help them. Ultimately, as nurses, our biggest thing is to help them with compliance. So here's all the different classifications of HIV medications. It's pretty funny. So in the 10 years, I guess now 13 years that I've been teaching, these combinations of medications have changed over the years. You know, like the prescription has changed. Some of these medications, like they just came out, like they've only been out in practice for less than 5 years. So lots of headway and research has been made in order to make these medications available to our population of people. One of the interesting things is that one of the medication classes we're talking about, the nucleosides and the nucleotides, you see here they're kind of combined together. Well, when I first started teaching, those were two separate drug classes. Only recently, within the last 5 years or so, have they actually had to combine those because of drug resistance. So these are our nucleosides, and you can kind of see here what they do. These are the medications that we will frequently see patients being given when they're first diagnosed with HIV. And again, it all kind of depends upon what type of HIV they have, what their viral load is, and what their overall health status is. Someone who has a lot of chronic conditions that then gets HIV piled on top of that, we're going to have a much harder time treating those patients because of those chronic disease processes. So our prototype here is going to be zidazavine, okay? Typically, we won't see this medication given by itself anymore. It's always with a friend, okay? And what happened is again, over time, as the medication was out there and people were non-compliant with it, or the virus just mutated, this medicine became not as effective as it was whenever it was used to be given alone. So because of that, you'll typically see the nucleoside and a nucleotide will be added up together. Here's kind of your basic side effects of everything that this medication could have. I gave this little dirty devil at the bottom because, again, this is one of those medicines that does not play well with others at all. So when we start mixing our HIV medications and just our basic like hypertensive medicines, we can get some really nasty side effects. So we've got to watch these patients. We got to be careful what other medicines they are on. Sometimes the medications or the treatments that we give patients make them sicker before they make them better. And this medication is absolutely no different. One of the biggest problems with this one is that the patient can suffer from bone marrow depression. So you have HIV, which makes you immunocompromised, and then you have another medication that's going to make you more immunocompromised. So you can imagine that this patient's opportunity to get some infections that they normally wouldn't have would be very, very high. Here's your NNRTIs. These are your non-nucleoside reverse transcriptase inhibitors, and this is what they do. Again, they're typically buddied up with someone else because we work better in pairs. This medication, again, you're not going to see it solo. It is absolutely typically butted up together. Things that you should know is that this one may cause a false positive for the patient to test positive for marijuana. And you can imagine if you already have the stigma of HIV and then having to go to your boss and explain why you're failing a urine drug test. Some of the same nasty side effects as we saw with the other classification of medication. Here we also have the impaired concentration. So for the first 3 to 4 weeks that they're on this medication, they may just kind of walk around in this brain fog all the time and be very sleepy. So we do recommend bedtime dosing. And the other odd thing about this medication is that we do recommend that you give this one on an empty stomach. So empty stomach, glass of water, that's it. Again, you see the little devil at the top of the corner because he doesn't play well with others either. Basically, none of our HIV medications play well with other people. We also see here that the risk of Stevens-Johnson syndrome is here. So a patient can develop a rash on this medication. That's just a rash. But if that rash begins to progress and get more aggressive and the skin layers begin to peel off, there is a risk for Stevens-Johnson syndrome. Here's your nucleotides. Again, they all kind of work a little bit the same, but then they have like a little key component that's just a little bit different that makes them even more effective in helping to keep HIV under control. The next medication is tenofovir. There's the only drug in its class. Thank you very much. Again, some of the exact same problems that we have with this medication that we have with some of the other ones. The difference between the nucleotides is that with this one, you can actually take it with food. So protease inhibitors, when they came out, they were kind of a game changer because they really kind of helped to stop the HIV cell from becoming into a mature cell. So it kind of like stunts it so it doesn't actually move anywhere or go anywhere. Problem is hepatotoxic. Over time, we developed a lot of drug resistance to it. So typically we see this combined with something else now. This drug prototype is lopinavir and ritonavir. So for this protein inhibitor, it's kind of interesting. When this one first came out, it was just ritonavir. And then the longer that it was out on the market, they realized that, okay, there's some interesting things that are going on here. So they added the lopinavir part to the front of the ritonavir. When they did that, what they realized is the ritonavir kind of helps act as a shield for the lopinavir so that it can actually work longer in the system than the ritonavir did. Okay. Other weird things that happens with this medication is they do have an increase in cholesterol and triglycerides, and sometimes they will actually suffer from pancreatitis because of that. So it's like, here's one more problem for you. I'm so sorry. Our fusion inhibitors, guys, these have only been out like less than 10 years. So they actually prevent, so the HIV cell goes into the body and then it finds a cell, but because we've got a fusion inhibitor in there, it's like doink, 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 doink. It can't even get to the CD4 receptor. So really cool to help patients to prevent them HIV from fusing into their body. The only problem is that this medication, the Fusion, we're just going to go with the brand name here, it has to be given sub-Q, and typically we only use that with really highly resistant strains of HIV. There's also another drug on the market called Selizentry. Yeah, I don't know how to say that one either. But there's another one on the market. Again, these medications, because of how specialized they are very expensive to use and typically reserved for those resistant strains of HIV. Big takeaways here is that we've got to teach compliance with our patients. They need HIV compliance with their regimen. If they don't have that, then the viral replication of the way the virus is produced in their bodies, there's a high degree of probability that they can develop a resistant strain of HIV. Whenever we do that, we get most concerned about them passing that virus on to someone else and it being even harder to control. We teach patients about the purpose of each one of their medications. We teach them about the dosage schedule. We tell them about the food and the fluid restrictions. We give them food choices. We tell them how they want to store their medications. We need them to process taking these medications just like they would take brushing their teeth or taking another pill or going to the bathroom first thing in the morning. We want to become that much of a rote memory that they can just take their pill without even thinking about it. We need to provide phone numbers and contact information of counselors and people for these patients to talk to, because chronic disease management, guys, is absolutely no fun. It's something you have to deal with every single day. There are a lot of side effects with these medications, and because of that, we need to give them options and opportunities to tell us about their side effects, and then we need to provide for them non-pharmacological ways for them to handle it. So for the nausea, maybe it is some essential oils, a cold wash rag to the neck. For the fatigue, it's taking a nap every day, making sure that we're not overstressing ourselves. Maybe before we start the medications, we tell them, like, look, for the next 3 to 4 weeks, you're going to need to initiate your short-term benefits at work, and then you're going to take that time off while you're getting adjusted. Maybe they don't have that option, but we try to plan ahead for these moments or for these times so that everything is just kind of taken care of. A lot of our local resources in town, we have something here called, oh, the name is escaping me. Yep, it's gone. Thought it was there. We have typically, okay, and in most places, you have organizations in your hometown that help take care of patients who have HIV. So maybe before you start them on they're starting on their regimen, maybe they're going to start on it next week. Then you help them to find people to provide them meals for 4 weeks. You help them to find people who are going to get their kids on and off the school bus. Whatever it takes in order to help to have this transition period and to make compliance better. Follow-up care. We want this patient to understand that it's not just going to be like come in and get your drugs and go. Instead, it's that we're going to require understanding of their laboratory levels to make sure that the medications that we're giving don't have hepatotoxic and nephrotoxic side effects. We want to make sure that the medication side effects are tolerable enough that they'll keep taking them. So really and truly, we have to bring them in, have the conversation, and then every 2 weeks we're going to do medications. And if we're changing meds or going down on medicines, then we may have them come back in more frequently. Again, we have to have compliance with this patient. They have to understand that while we are making these, making these choices and changes in their medication therapy, that we need frequent contact with them so that we can make sure that they're in their healthiest possible place, helping them to feel like they're part of our healthcare team and really listening to them, because I feel like that's half the battle is they just don't feel like they're listened to whenever they come in and talk about their side effects. One of the things that happens to HIV patients is if their CD4 count is really, really low, and remember your CD4 are the guys inside your body that are constantly scanning and looking for the bad guys. And when they see a bad guy, they're like, Roger, Roger, hold on, immune system, we need help down here, we need help. And it sends all the guys to whatever infected agent is there so it can kill them. If we lose our lookouts, then patients are going to be getting these infections that they normally wouldn't get if they had a competent immune system. So we see a lot of these things come up that you're just like, oh my gosh, this patient is so sick. Why are they so sick? I remember a patient coming to the emergency department one time, and he was sitting in the hallway and he was so sick. He was a Hispanic man and he was kind of gray and ashy looking, and I didn't know what was going on. And all I could think about is that, man, this guy is so incredibly sick. Well, come to find out, he actually was HIV positive, and he had not only tuberculosis manifestations, but he also had pneumocystis carni and a horrible yeast infection, like an inside of his mouth. It was all over his lips and his tongue, and he was miserable, miserable. So typically when we find these patients and they've had these pop up, these opportunistic infections, it's typically the first time we see them in healthcare. So again, with these patients, they may be taking these antiviral drugs to keep their viral loads low, their CD4 is high, so they don't get these, and to help the patients understand how horrible some of these opportunistic infections are that they could potentially get from their environment. We do have a lot of infants that are born worldwide, even here in the United States, that are born to HIV-infected mothers. We have a game plan. If the mom is HIV infected, there is a high degree of probability that we can prevent the child from ever becoming HIV positive, ever converting. And the way we do that is giving medications starting in the 14th to the 34th week of gestation when the mom is pregnant. So that hopefully those are being passed on to the baby. Then during labor, we have medications. And then as soon as the baby is 6 hours old, then we start giving them antiretroviral therapies. Sometimes this will prevent the child from ever becoming HIV positive. Unfortunately, as a healthcare provider, there is an opportunity for you to be exposed to HIV with any kind of blood or body fluids. The first thing you want to do is, if you've been stuck by a needle or whatever, you want to finish up what you're doing. You want to milk the blood out of it as fast as you can, go to the sink, wash it all out, tell your supervisor, and you're going to the ER. Once you're in the emergency department, we will do studies on both you and on the person's blood that happens to be in you, because we need to know if they're HIV infected, what's their viral load. If their viral load is very high because they've not been med compliant, there is a huge risk to you that you could progress and get the disease. So again, understanding what your risk is. Blood carries more HIV than other substances. If it's a deep, hollow bore needle, it's more of a problem than if it was a scratch or you got spit on or got peed or pooped on. So again, we want to get baselines on the patient, baselines on you, and then they're going to offer you post-exposure prophylaxis known as the PEP treatment. You can find more information about the PEP treatment at cdc.gov. Now we're going to shift our focus a little bit out and away from HIV and going to be talking about herpes. Herpes, that's right, good old-fashioned herpes. So the herpes simplex virus comes in a couple of different forms. We see it manifested as herpes simplex virus type 1, type 2. Type 2 is the shingles and the chicken pox. Also cytomegalovirus, Epstein-Barr virus, also known as mono, and herpes 6 virus known as roseola. Those are all herpes viruses. The good news is that for our HSV1, HSV2, varicella, and our zoster, which is our shingles and our chickenpox, we can give a cyclovir, famciclovir, or a valcyclovir for those infections. So one of the weird things that's happening now in the public is we used to say that HSV1 was up here on the lip and HSV2 was down below. Well, that's not true anymore. So now HSV1 is now showing up on genitalia. So when you do samples, take cultures from patients whenever they come in with lesions, it can be HSV1 or HSV2. Usually herpes simplex virus 2, the first episode outbreak absolutely runs most patients to the emergency department because it is very, very painful. With our herpes, we know that we have two different types of the disease. We have the latent, which means that you get the infection and then it just kind of goes to sleep. And then you have the active form. With the active form, even if it's asleep, then if you have like a stressful event, a physical challenge, an emotional stress, it can reactivate it and quote unquote turn it back on. Ultimately, our goals of therapy are to provide you some relief and to prevent some reoccurrences. But to prevent the reoccurrence, we really need to start treatment on you within less than 24 hours of the first lesion showing up. Sometimes that can be a little bit tricky with some lesions because people think, oh, it's just a bump or a razor burn or whatever. If a patient is having more than 6 episodes of an outbreak of herpes within a year, we probably will start them on a prophylactic therapy in order to kind of keep them in check. So acyclovir would be our prototype drug for our herpes viruses. Again, need to get to you within 24 hours of any kind of vesicles appearing, whether it's from the chicken pox, it's herpes down there, herpes up here. If we're going to give you oral acyclovir, it needs to be within 24 hours. Remember that even though we're giving you the acyclovir, that still doesn't mean that you're like, oh, I no longer have herpes. No, it's just a suppressive drug, sweetheart. You could still pass that on. So I want to make sure that patients are aware of that. The good news is that with any herpes virus, it doesn't matter if this is your first one is always the worst one, and then after that, it tends to not be as severe. Anytime I have patients that have vesicles that are near their eye, that is an emergency. If those vesicles get into the eye, like if a patient has shingles or chickenpox and they physically get into the eye, they can actually cause blindness. So those type of, when they get near the eye, nope, not playing with you. It is an emergency because if we don't get that prompt treatment started on that patient, they can lose their vision. Oh, influenza. If I could tell you about influenza, how many times I've seen it, it is ridiculous. People, get your flu shots. The absolute best treatment is prevention. If the patient is greater than 6 months old, if you are a healthcare worker, if you are anybody, the only contraindication for you getting the flu vaccine 9 times out of 10 is if you have an egg allergy. And there's not very many egg allergies. In fact, that's not even going to be that's going to be a moot point in a few years because we've got vaccines that are coming out that are not made out of eggs anymore. So very important that we get our patients, that we ourselves get our flu shots. I will tell you that this last year's experience with the flu, what I saw was that there were people who got their influenza vaccine and still tested positive for the flu. The people who got their vaccine but tested positive, they were down, okay? They didn't feel great, but they were still moving. If you tested positive for the flu and you didn't get your flu vaccine, girlfriend, you weren't only down, you were also down and out. Bad. Like curled up in a ball on the couch wishing that, your life was somewhere else, okay? So again, very important that if we encourage all of our patients to get the flu vaccine and that we ourselves are good stewards of it. Please remember that when you get your flu vaccine, for the next 2 to 3 days, you need to plan on not feeling well. Your body needs to make antibodies, okay? It has to activate your immune system. It's okay to go home and take an extra nap. It's okay to do it on a weekend when you're off so that you can recover from it. So again, when you plan to do your flu vaccine, I always plan to do mine on Wednesday because I know that Thursday I'm going to feel okay, Friday morning I'm okay, Friday afternoon not so well. Saturday, I'm going to watch Netflix all day long. Sunday, I'm going to watch Netflix all day long. And then boom, I'm back up and ready to go by Monday. But I had to give my body time to make those antibodies. So encourage your patients. They're like, I always get the flu. And the answer is you got to form the flu, but it wasn't near as bad as what it could have been. We do have medications if patients get the flu, even if they've had the flu vaccine or if they were unlucky enough not to get their flu vaccine. Every year, I laugh about this. People are like, I just couldn't find time. I'll make an excuse to go to the Texas Reds Festival every fall because not only is there wine, I also get my flu vaccine and it's free. There's tons of places in town that give away the flu vaccine for free, so please take advantage of it. The medication here that we're talking about is Tamiflu. Tamiflu does work well to help to shorten the duration of the flu if you were to get it. It kind of takes it from having a full 5-day course to decreasing it down to 2. Be very careful when you give it to children because there has been some studies that said that it can cause suicidal psychotic episodes in children. So again, the best option is to prevent the flu from ever happening. Just get your dang flu shot, people. Hepatitis. Ooh, what a barrel of monkeys it is. Trust me, this is as easy as ABC. Let's talk about hepatitis A first. So hepatitis A, you get via the oral fecal route. Thank God there's a vaccine for that. Typically, whenever patients are exposed to hepatitis A, it's usually in unsanitary conditions. We do have a post-exposure or prophylaxis hepatitis A immunoglobulin if we need to give it. It will give you passive protection for about 3 months. But again, the best for this one is vaccination. Hepatitis B. Hepatitis B is a horrible disease to have. And so because of that, they've basically gone to universal vaccination. It helps to decrease the patient's risk of developing cirrhosis and hepatocellular carcinoma. Guys, it's just important. The good news is that if you're exposed to hepatitis B and you're a non-converter or someone who never has a positive titer for hepatitis B, we do have hepatitis B immunoglobulins that we can be administered. Hepatitis C. Again, exposure to blood or body fluids, it's the most common cause of liver transplants today. This virus, just like any other virus, it can go active or it can be latent. Some patients will have these latent forms of the disease and don't even know it for years. The cool thing is that we now have a cure for hepatitis C. Probably the most familiar one that I'm with is, they call it Maverick. I call it Maverick because it helps to it kicks hepatitis C's butt. It has almost a 95% cure rate with hepatitis C. This program, or hepatitis C cures, used to cost thousands, like $30, $40, $70, $80,000. Now they're not like that anymore. A lot of the programs will help to waive the fees of the medication, and the only thing that you would have to pay for is actually the laboratory studies, which is less than $1,000 for a cure for a disease that could eventually cause you cancer. All right, everyone, that's all about viruses. Hope you guys learned a lot, and I'll talk to you soon.